Welcome to the Radox Smart Review CNS Cancer Series. Today, we're diving into, well, a really crucial area of CNS radiation oncology, high-grade glioma part 2. Our focus for this deep dive is specifically on anaplastic astrocytoma and the really big shift towards what we now call molecular grade 4 tumors. This field, honestly, it's incredibly dynamic, isn't it? It's constantly changing how we think about cancer way beyond just what we see under a microscope. It's really where genomics is redefining everything: diagnosis, prognosis, treatment.
That's a perfect way to put it, yeah. In our last session, we kind of laid the groundwork, right? We set up the modern molecular framework for diagnosing these high-grade gliomas, and we went into detail on managing anaplastic oligodendroglioma. So today, yeah, we're looking at the other side of that molecular coin, building on that essential foundation we established. Our mission for this discussion, it's pretty ambitious. We really want you to master the management of anaplastic astrocytoma. We'll do that by dissecting a really key, practice-changing trial, the CATNON trial. CATNON. And then we're going to tackle, well, a challenging but incredibly important new player introduced in the 2021 WHO classification, the IDH-mutant astrocytoma, grade 4. Now, this isn't just a new name. It's a tumor that might, look lower grade under the microscope, maybe even seem deceptively less aggressive histologically. But it carries a much, much graver prognosis and absolutely demands a different treatment strategy based entirely on its genetics. It really embodies this whole precision oncology revolution we're seeing.
Okay, perfect. Let's ground this with a case then. Make these concepts a bit more concrete, more relevant for everyone listening. So imagine you're in clinic and you're seeing a 38-year-old woman. She initially came in with, pretty common symptoms for a brain lesion, persistent headaches, and some noticeable trouble finding her words. These symptoms, while often benign, were, well, concerning enough in her case to trigger a full workup.
Exactly. And her MRI confirmed those suspicions. It showed an irregularly shaped mass in her left parietal lobe. Importantly, it was non-enhancing, and T2 and FLAI are hyperintense. Now, that non-enhancing feature on the MRI is actually a really crucial detail here, because historically, that finding might have led clinicians to lean towards suspecting a lower grade lesion, maybe even thinking grade 2 initially, which just highlights precisely why this comprehensive molecular workup has become so absolutely vital. So she underwent a subtotal resection, meaning not all the tumor could be removed safely, and the preliminary pathology report just came back saying anaplastic glioma grade 3.
And right there, for us as radiation oncologists, that initial diagnosis, it's helpful, sure, but it's just not enough anymore, is it? It's a start, definitely, but it doesn't give us the detailed roadmap we absolutely need for modern practice. To really formulate a precise, evidence-based, and effective treatment plan today, you absolutely unequivocally need to know which specific molecular pathway this tumor belongs to. You need that detail from the modern classification algorithm. So what happens next? What's the critical piece of information we're really waiting on to make those definitive treatment calls? Because without it, we're kind of flying blind, right?
You're absolutely right. That initial path report is just, well, the opening scene. The real story, the definitive fingerprint that guides our entire strategy that comes with the final integrated report. And for our patient, that crucial report revealed her tumor's precise molecular signature. It was isocitrate dehydrogenase, or IDH mutant. It was 1P and 19Q non-codeleted, and it showed loss of ATRX expression. ATRX, this exact combination IDH mutant, 119Q intact, ATRX loss. That's the core definition of our topic today. Anaplastic astrocytoma. It lets us move way beyond those older, broader, sometimes ambiguous categories and really tailor our approach with much greater specificity and, importantly, with solid evidence backing us up.
Okay, so let's just lock that diagnosis down for everyone listening. Let's walk through the WHO algorithm quickly just to make sure we're all clear on how we arrived here for this patient. Following the World Health Organization, or WHO, algorithm, the first big decision point for diffuse gliomas is IDH status. And for our patient, it's clearly IDH-mutant.
That's the critical first step. Yep.
Yeah.
Once we know it's IDH mutant, the next crucial question in that algorithm is about the 1P and 19Q status. Because her tumor is non-codeleted, or as we often say, intact, that immediately tells us we are dealing with an astrocytic tumor. Just to refresh from our last discussion, if it were codeleted, that would point straight towards an oligodendroglioma.
Right, a completely different entity.
Exactly, different management, different prognosis. So non-codeleted means astrocytoma lineage. Then the characteristic loss of the ATRX protein further confirms this. For those wondering, ATRX is a protein involved in chromatin remodeling, basically organizing DNA in the nucleus. Its loss often leads to genomic instability, which is a hallmark of these specific astrocytomas, and it strongly points to their astrocytic lineage. It helps separate them from oligos. So putting it all together, IDH-mutant 119Q intact, ATRX loss, our patient definitively has an anaplastic astrocytoma, WHO grade 3. A little mnemonic that might help you remember the key features for anaplastic astrocytoma, think IDH-ATRX 1P19Q intact.
I like that. IDH-ATRX 1P19Q intact.
Exactly. Cover to the bases.
And this precise molecular diagnosis, it really sets her apart in a major way, not just slightly from the patients we discussed last time, like those with anaplastic oligodendroglioma. It's a fundamental difference that completely changes how we see the disease. The prognoses are totally different, and crucially, the evidence guiding our treatment is also different. This molecular-guided precision, it's not just academic jargon. It is absolutely key to giving the most effective, personalized care possible in modern neuro-oncology. It moves us way beyond those old, broad classifications.
You've nailed the core principle there.
Yeah.
And for anaplastic astrocytoma specifically, the central piece of evidence, the landmark study that truly revolutionized our practice and set the current standard of care. That's the CATNON trial, CATNON. This is a study that every single radiation oncologist treating brain tumors, frankly, every neuro-oncologist needs to know inside and out, because it answered a critical question that honestly we struggled with for years.
Okay, tell us more about CATNON then. What was its main goal? What was the overall design? What specific clinical questions was it trying to resolve for this particular group of patients, especially given the uncertainty that existed before the trial?
Well, before CATNON, clinicians often had to make, educated guesses.
Yeah.
Or maybe even worse, sometimes they'd apply treatment paradigms from glioblastoma to these anaplastic glioma patients, which potentially exposed them to unnecessary toxicity. It created a lot of deviation in practice. So the CATNON trial, which was led by the European Organization for Research and Treatment of Cancer, the EORTC.
EORTC, right.
It was designed specifically to answer that fundamental treatment question for this population. The 1P and 19Q non-code-leaded anaplastic gliomas. The core question was essentially, what's the best way to sequence and combine radiation and the chemotherapy drug temozolomide, KMZ? Should TMZ be given concurrently with radiation? Should be given as adjuvant therapy after radiation? Or maybe both? This was so important because TMZ had already shown effectiveness in other gliomas, especially GBM. So figuring out its optimal role here was absolutely critical for truly personalizing treatment.
And how did they actually go about answering that, well, pretty complex question? What did the trial structure look like? It sounds like it needed to be pretty sophisticated to tease out the best approach among several possibilities.
It was, yeah. It was an ambitious and really elegantly designed study. They used a 2x2 factorial design, which is a clever setup. It allowed them to independently test the impact of concurrent TMZ and adjuvant TMZ all within the same trial. It's a very efficient way to answer multiple questions at once. They randomized over 750 patients into 4 distinct treatment arms. First arm, radiation therapy alone, delivered to 59.4 gray. This was the baseline control, kind of the historical standard without TMZ.
Okay, standard RT.
Second arm, radiation therapy or RT, followed by adjuvant TMZ. So TMZ given after radiation, typically for 12 cycles. This tested the benefit of TMZ as like a maintenance therapy.
Post-RT chemo.
Right. Third arm, RT with concurrent TMZ. So TMZ given daily during the radiation course. This mirrored the standard GBM approach at the time, testing if that concurrent chemo helped here too.
The step-like approach.
Exactly. And the fourth arm, RT with both concurrent and adjuvant TMZ. This combined the previous two, the most intensive chemo regimen, testing if, more is better.
Okay, let's unpack those results then, because you said they're truly practice-defining. They've really reshaped how we approach these specific tumors. What did the interim analyses and maybe more importantly, the final 2021 analyses show, especially regarding the role of that adjuvant TMZ?
Right, so first focusing on adjuvant TMZ, the trial delivered a really clear, total unequivocal, and profoundly positive result. This was a huge win for patients. A key finding is that adding those 12 cycles of adjuvant TMZ after radiation significantly improved the 5-year overall survival. It jumped from 44% in the RT alone group to 56% in the RT plus adjuvant TMZ group.
Wow, 44 to 56%. That's a 12% absolute improvement at 5 years. That's substantial.
It's a really substantial improvement, yes. It translates directly into significantly more patients living longer, living better.
This finding fundamentally and without question established a new standard of care for this specific patient population. It wasn't just, a marginal gain. It was a robust, clinically meaningful difference that really demanded widespread adoption.
Okay, that's a definite win, a clear step forward, offering a real increase in survival. But now, what about the concurrent TMZ? The role of giving chemo during radiation is so deeply ingrained in our thinking for other high-grade brain tumors, especially GBM, it was almost assumed it would be beneficial here too. What did CATNON tell us about that? Were there any surprises?
This is really where things get fascinating. And it provided a crucial, maybe even surprising distinction that definitely challenged some prior assumptions. The final analysis, published in 2021, it clearly showed that adding concurrent TMZ to radiation provided no overall survival benefit at all for this specific patient population.
No benefit, seriously.
Zero benefit in terms of overall survival. The 5-year overall survival rates were remarkably similar, around 50 to 53%, whether concurrent TMZ was given or not.
Yeah.
This was a critical negative finding. It fundamentally showed that, unlike in glioblastoma, where concurrent TMZ is absolutely essential and provides a survival advantage,
Right.
for anaplastic astrocytoma, this specific group, the concurrent part of the therapy, just isn't beneficial. Which is great news in a way, because it allows us to avoid potentially significant toxicity without compromising the outcome. That's a huge win for patient quality of life.
So for these patients, giving TMZ during radiation just adds side effects, things like nausea, fatigue, low in blood counts, infection risks, without actually helping them live longer. That's a super important distinction for clinical practice. It saves patients from those side effects while still ensuring they get the best outcome. Now, you mentioned earlier the profound power of molecular classification. What about the molecular sub-analysis within CATNON? This is often where the real magic of personalized medicine reveals itself, isn't it?
Absolutely. This is precisely where the story gets even more compelling and truly cemented why molecular classification is paramount in guiding therapy. When the investigators did a careful sub-analysis breaking down the outcomes based on IDH status, well, a clear, unmistakable, and profoundly important pattern just jumped out. The survival benefit from adding adjuvant TMZ, it was seen only in the IDH-mutant population.
Only in the IDH-mutant group.
Only. For these patients, adding adjuvant TMZ was nothing short of transformative. It extended the median overall survival from about 47 months in the RT alone group to a remarkable 82 months. That's nearly 7 years for those getting RT plus adjuvant TMZ.
Wow, from roughly 4 years to almost 7 years median survival.
Exactly. Think about that, nearly doubling the median survival time for a patient. And the updated 2021 results push this even further. The median overall survival reached an astounding 98 months for IDH-mutant patients who received adjuvant PMZ.
98 months. That's over 8 years.
Just over 8 years median survival. It's an incredible testament to the power of targeted therapy based on these specific molecular markers.
Okay, wow. Pushing close to 8 years median survival is truly significant. A huge improvement, profoundly highlighting how molecular classification doesn't just predict, but actually dictates response to therapy. It really changes what was once a much bleaker outlook. So what about the IDH wild-type group within CATNON? Did they see any similar benefits from getting that adjuvant TMZ?
Unfortunately, no. And this is equally important. In the relatively small subset of patients in CATNON who had IDH wild-type anaplastic astrocytoma, and remember, according to the updated WHO guidelines, we would now molecularly classify these tumors as GBM, glioblastoma, regardless of their histologic grade, simply because they are IDH wild-type.
Right, that's a key point from the new classification.
Yes. For that group, adjuvant TMZ provided absolutely no benefit whatsoever. Their median survival remained depressingly poor, stuck at around 20 months, regardless of which treatment arm they were in. This stark difference just underscores how absolutely critical molecular subtyping is. It's essential for accurate prognosis and for making informed, evidence-based treatment choices. It stops us from giving patients toxic therapies that won't help them while making sure those who will benefit get the right life-extending treatment. It's truly about the right treatment for the right patient.
So, okay, bringing it back to our 38-year-old patient. She has the IDH-mutant anaplastic astrocytoma. The CATNON trial gives us a crystal clear, unambiguous answer for her standard of care. There's really no guesswork involved here, is there?
You're absolutely right. The standard of care, based squarely on the robust evidence from CATNON, is radiation therapy to 59.4 gray.
Yeah.
typically delivered over about 6 weeks, followed by up to 12 cycles of adjuvant TMZ, usually given in that 5 days on, 23 days off schedule. For our patient, deciding to omit adjuvant chemotherapy would be a significant and honestly an indefensible deviation from the established standard of care. It would undeniably compromise her long-term outcome. It's not just a matter of clinical preference. It's about applying powerful, evidence-based oncology that we know extends lives.
Okay, that's very clear for the grade 3 anaplastic astrocytoma. Now let's pivot slightly and address this new and, well, challenging entity that really highlights how fast glioma grading is evolving and the increasing power of molecular markers. I'm talking about the astrocytoma IDH-mutant WHO grade 4. What exactly defines this molecular grade 4, especially since, as you mentioned, it might not actually look like a grade 4 under the microscope, which sounds pretty counterintuitive.
This is a really crucial concept and maybe the most significant conceptual shift in the entire 2021 WHO classification. It truly embodies this massive paradigm shift towards molecular grading. What it fundamentally means is that a tumor might histologically look like a grade 2 or maybe a grade 3 astrocytoma under the microscope. It might lack those classic high-grade features we traditionally associate with GBM, like necrosis or microvascular proliferation. But crucially, it harbors a specific high-risk molecular feature that automatically gives it the prognosis and the biological behavior of a true grade 4 tumor. Think of it like this. Maybe an analogy helps. Imagine a car that looks like a standard family sedan on the outside, maybe even kind of quiet and unassuming.
Okay.
But under the hood, it's got a souped-up high-performance racing engine.
I see.
That engine, regardless of the car's outward appearance, dictates its true speed and power. That's exactly what an IDH-mutant astrocytoma grade 4 is like. Its microscopic appearance can be misleading, but that specific molecular alteration is its high-performance engine, driving aggressive, grade 4 behavior and prognosis. This isn't just slapping on a new label. It's a profound statement. What a tumor is molecularly now outweighs what it looks like microscopically. It forces us to embrace genomics as the ultimate arbiter of prognosis and treatment.
So it's truly about the deep down biology, the genetic drivers, not just the superficial cellular appearance. That's a huge shift from traditional pathology. What is that key molecular feature then? What's the specific genetic engine, as you put it, that automatically upgrades a seemingly lower grade astrocytoma to a WHO grade 4?
The defining alteration, the specific high-risk molecular feature we're looking for, is a homozygous deletion of the CDKN2A and B gene, CDKN2A and B.
Okay, CDKN2AB homozygous deletion.
Exactly. Now, for context, CDKN2A and B are crucial tumor suppressor genes. They basically act as the brakes on uncontrolled cell division. When you have a homozygous deletion, it means both copies of these critical brake genes are completely gone, completely lost. This basically removes the brakes, unleashing uncontrolled cell growth. It fundamentally transforms a seemingly lower-grade tumor into a highly aggressive one, regardless of how it looks under the microscope. The diagnostic implication is paramount. It's automatic. If you have an IDH-mutant astrocytoma of any histologic grade, could look like grade 2, could look like grade 3, that also has a homozygous CDKN2A and B deletion, it is automatically upgraded to WHO grade 4. Full stop.
Non-negotiable.
Non-negotiable in the new classification system. And that has immediate critical implications for how we think about prognosis and how we approach treatment.
That's a massive shift in classification with really profound implications for how we view these tumors and, more importantly, how we treat them. So, given that we might be dealing with a tumor that looks lower grade histologically but molecularly is screaming grade 4, how aggressive are these molecular grade 4 tumors in reality? And what are the current ways we approach treating them, especially given they lack those classic histological grade 4 features? This sounds like it could be a tricky conversation to have with a patient.
It absolutely can be a challenging conversation, yeah, but it's a vital one. While these specific tumors, this newly defined molecular grade 4 category, are relatively rare, they are indeed significantly more aggressive than their grade 2 or 3 counterparts that don't have the deletion. Retrospective data clearly shows they behave much more like glioblastoma in terms of how quickly they progress and patient survival. Now, as for treatment, this is currently a point of considerable controversy, largely because, well, it's such a newly defined entity, there's a critical lack of direct prospective evidence from a dedicated clinical trial to guide us. The NCCN guidelines, they acknowledge this uncertainty. And reflecting this ongoing debate, they suggest these tumors can be treated either like grade 3 astrocytomas, following the CATNON approach.
So RT followed by adjuvant TMZ,
Right. Or, more aggressively, like glioblastoma.
meaning RT with concurrent and adjuvant TMZ.
Exactly. However, given their definitively poor prognosis, which is already clear from the observational data we have, most experts would argue for taking a more aggressive approach right from the beginning. Imagine explaining to a patient that what looks like a relatively less aggressive tumor under the microscope is actually behaving like the most aggressive type of brain cancer because of one specific genetic deletion. It's a tough message.
Yeah, that's a heavy conversation.
And it forces a very different discussion about the intensity of treatment needed.
So when you say more aggressive approach, what does that usually mean in practice for these molecular grade 4 IDH-mutant astrocytomas, especially since, as you said, we don't have a dedicated landmark trial like CATNON specifically for them yet? Are we basically borrowing from other paradigms, and how comfortable are we doing that?
Yes, exactly. It is reasonable, and it's actually common practice now among neuro-oncology experts to extrapolate from the glioblastoma paradigm. We do that because of the shared aggressive biology and the uniformly poor prognosis these tumors show, despite their sometimes misleading histology. Therefore, many, probably most experts would treat these patients with the full STUP protocol,
Okay, the full step.
which means 60 grays radiation, usually over 30 fractions, given with both concurrent TMZ during radiation and then followed by 6, maybe up to 12, cycles of adjuvant TMZ. This approach aims to maximize the therapeutic punch against a tumor that we know is inherently aggressive. However, and this is a big issue, however, it's vital to remember this is an area of very active investigation. The huge unanswered question is, do these IDH-mutant molecular grade 4 tumors truly benefit from the concurrent part of the TMZ, like IDH wild-type GBM does?
Right.
Or would adjuvant TMZ alone, after radiation, be sufficient, similar to their grade 3 counterparts defined in CATNON?
That's a key question because of the added toxicity.
Precisely. Concurrent TMZ adds toxicity. So these patients are truly ideal candidates for enrollment in dedicated clinical trials. We desperately need more direct prospective evidence to definitively figure out and optimize their treatment. Understanding their distinct biology is really paving the way for those critical future trials.
All right, that makes sense. Let's shift gears slightly and distill this down into some clinical pearls. These are the concise, high-yield takeaways that everyone listening can carry right into their clinic or maybe into their board exams. These are the absolute must-knows.
Sounds good. Yeah, here are the absolute key takeaways for anaplastic astrocytoma and this crucial concept of molecular grade 4. First, an anaplastic astrocytoma is defined molecularly. It's an IDH-mutant 1p19q non-codeleted glioma. Remember, 1p19q intact. It also almost always shows ATRX loss, which helps confirm its astrocytic lineage and signals that genomic instability.
Got it. IDH mutant, 1p19q intact, ATRX loss.
Second, the CATNON trial. That is the landmark study for this disease. It showed without a doubt that adjuvant TMZ significantly improves survival. But crucially, concurrent TMZ does not add further overall survival benefit, only toxicity.
Adjuvant, yes. Concurrent, no. Clear.
Third, the numbers from CATNON are important. 5-year overall survival improved significantly, from 44% to 56%, just by adding adjuvant TMZ. And importantly, this benefit was limited entirely to the IDH mutant population. Their median overall survival is now approaching that impressive 8-year mark.
8 years for IDH mutant with adjuvant TMZ.
Okay. And finally, number 4, astrocytoma, IDH mutant, WHO grade 4. This is a newly defined molecular entity. It's an IDH mutant glioma that has a homozygous deletion of CDKN2A and B. This deletion confers a significantly worse prognosis, regardless of how it looks under the microscope, and therefore strongly justifies a more aggressive treatment approach, often borrowing from GBM protocols for now.
Excellent synthesis. Really clear pearls. Now, are you ready for a quick board blitz? Let's test these concepts and lock them in. These are exactly the kinds of questions and scenarios you might face in exams or just thinking through cases in clinic.
Absolutely. Let's do it. Let's put it all together and see how these concepts apply in practice.
Okay, case 1. You have a 40-year-old woman. She undergoes a subtotal resection of a grade 3 glioma. The final pathology report comes back. IDH mutant and 1p and 19q non-codeleted. Based on the practice-changing CATNON trial, which adjuvant regimen provides a proven overall survival benefit for this patient, is it A, None. Radiation alone is sufficient. B. Concurrent TMZ given daily during radiation. C. Adjuvant TMZ for 12 cycles after radiation. Or D. Both concurrent and adjuvant TMZ.
Okay, the best answer here, clearly, is C, adjuvant TMC, for 12 cycles after radiation. The clinical reasoning comes straight from the CATNON trial's main finding. The primary result was that significant overall survival benefit came from adding adjuvant TMZ after radiation. The trial specifically found that adding concurrent TMZ during radiation was futile. It didn't improve survival for these patients, only added toxicity. So for an IDH-mutant 119Q non-codeleted anaplastic astrocytoma, adjuvant TMZ post-RT is the standard.
Perfect. Case 2. Same 4-year-old patient. She now asks you about her prognosis, understandably. You explain that based on the CATNON data, specifically for IDH-mutant tumors treated with radiation and adjuvant TMZ, her expected median overall survival is approximately what? A, 2 years, B, 4 years, C, 8 years, or D, over 15 years.
The best answer here, reflecting that huge impact of molecularly guided therapy, is C, approximately 8 years. The CATNON trial, especially with those updated 2021 results, showed that robust median overall survival of 82 to 98 months, which translates directly to around 7 to 8 years, and that's specifically for the IDH mutant subgroup who received radiation followed by adjuvant TMZ. It really highlights how important that molecular information is for prognosis and treatment.
Excellent. Case 3. Now, 35-year-old man undergoes resection of a tumor. When the pathologist first looks at it under the microscope, histologically it's classified as a grade 2 astrocytoma. Looks lower grade. However, the full molecular report comes back and definitively shows an IDH mutation and, critically, a homozygous deletion of CDKN2A. Based on the 2021 WHO integrated classification, what is the correct definitive diagnosis for this patient? A. Astrocytoma IDH mutant grade 2. B. Astrocytoma IDH mutant grade 3. C. Astrocytoma IDH mutant grade 4. Or D. Glioblastoma IDH wild type grade 4.
The correct answer, which really captures that core principle of modern molecular grading, is C. Astrocytoma IDH mutant grade 4. The presence of that homozygous deletion of CDKN2A and B in an IDH mutant astrocytoma automatically definitively upgrades the tumor to WHO grade 4. It doesn't matter what the initial histology looked like. That molecular finding supersedes the histology in determining the tumor's true biological grade and its prognosis. It's a key principle of the 2021 WHO system. We look beyond the appearance to understand the underlying biology.
Okay, that concept of molecular grade 4 definitely adds a new, important layer of complexity to managing gliomas. It really pushes us to rethink traditional grading systems. What are some of the ongoing discussions or maybe active areas of research in this space, especially given how relatively new this specific classification is? It sounds like there's still quite a bit to figure out.
You're absolutely right. This is really where the cutting edge of neuro-oncology meets, well, clinical uncertainty. As we've discussed, the optimal treatment for astrocytoma, IDH mutant, WHO grade 4, it's currently a point of significant discussion, even controversy, among experts. And that's primarily because we lack that direct prospective evidence from a dedicated trial to really guide us. Now, extrapolating from the glioblastoma paradigm, treating them aggressively with concurrent and adjuvant TMZ, that's common practice for most experts now, given the clear, poor prognosis seen in retrospective data. But it is an area of very active investigation. The big unanswered question remains, do these tumors truly need the concurrent TMZ component like IDH wild-type GBM does? Or would adjuvant TMZ alone after radiation be enough, similar to the grade 3 tumors in CATNON?
Right, avoiding that extra toxicity if possible.
Exactly. So these patients are truly ideal candidates for enrollment and dedicated clinical trials. We desperately need that direct evidence to solidify the optimal, most personalized treatment for this newly defined molecular entity. Understanding their distinct biology isn't just academic, it's absolutely essential for designing the future trials that will ultimately resolve this crucial controversy.
Okay, great. So, to summarize today's deep dive then, we've effectively wrapped up our comprehensive look at WHO grade 3 gliomas. We've carefully separated the management of oligodendrogliomas, which we covered last time, from anaplastic astrocytomas. And we based that separation squarely on their distinct molecular profiles and the landmark trials, like CATNON, that now rigorously guide our practice. And maybe most importantly, we introduced and really explored this powerful, game-changing concept of molecularly defined grade 4 astrocytomas, highlighting how specific genetic changes can completely redefine a tumor's behavior, its prognosis, and how we need to treat it.
Precisely.
We defined anaplastic astrocytoma, IDH-mutant 119Q non-cotyleded, often with ATRX loss. We thoroughly analyzed the pivotal CATNON trial, which established unequivocally that for these tumors, adjuvant TMZ after radiation significantly improves 5-year survival from 44% to 56%. And that benefit was driven almost entirely by the IDH mutant group, where median overall survival is now impressively approaching 8 years.
And we clearly defined that new clinically vital entity, astrocytoma IDH mutant grade 4, which gets automatically upgraded to the highest grade based on that homozygous deletion of CDKN2 AB, a critical molecular marker that signals a much worse prognosis and therefore warrants a more aggressive treatment approach, often borrowing from GBM protocols until we get more specific evidence.
Exactly. So in our next deep dive, we're going to shift our focus entirely to the most common and arguably still the most challenging high-grade glioma, GBM, glioblastoma, IDH wild type. We'll do an in-depth exploration of the STUP protocol, why it remains our cornerstone therapy even after all these years, and we'll critically review the many, many negative trials that have, unfortunately, only reinforced its standing. It really illustrates just how difficult it is to make progress in GBM treatment. That will bring our high-grade glioma series to a powerful conclusion.
Sounds great. Don't miss our next episode. And remember, you can complete practice oral boards and find more learning resources at radonsmartlearn.com. That's radonsmartlearn.com.
Thanks for tuning in to this deep dive on anaplastic astrocytomas and molecular grading. We really hope this conversation has given you a clearer, more nuanced understanding of these complex tumors and how molecular classification is fundamentally reshaping everything we do.